Welcome all on the medical MCQ for all. I am Dr. Munjal Pandya. So this is what the thing is, as you must be knowing. So we can skip little fast, so we can jump to the main things. We are the company providing PROMETRIC coachings, book, website, online subscription, WhatsApp subscription, short package, and data flow services. So whatever you need to get for to get the exam, to pass the exam, we'll provide almost everything. This myself, I am a practicing hemato-oncologist and bone marrow transplant fellow, practicing for almost 20 plus years with teaching experience of more than 10 years, treated so far 100,000 patients, especially hemato-oncology. This is another excellent speaker in my team. Dr. Arti is a consultant pediatrician. Dr. Maddie, she is again an emergency physician and main coach for Oman Vaiva. She is based at Oman. Dr. Shikha, she is a consultant gynecologist. She is also taking regular lectures every day. All right. For OBGY is Dr. Ankit Patel. He is a consultant gastroenterologist. He is again excellent speaker and coach mentor for all various exams. So this is a team and this is little more bigger than this. So this is our contact detail. Recently we updated one book called ProMetric 1000 MCQ book with answers and explanation. Recently updated with many updated questions. So those who wants, they can order it online. ProMetric 1000 MCQ book. And uh, last but not the least, recently we launched excellent mega offer for coaching. Earlier, the 40 hours coaching used to be 500 USD, but now with management and company decided to give mega discount, so now it's available in 250 USD. So I think this is the golden opportunity. Who has a very short time, probably 1 month to prepare, they can go for it. And this is the data flow, right? So Dr. Anjali Sawant, who is based at Dubai, she is taking care of data flow. So anyone needs data flow, exam booking, or any other queries, feel free to call directly to Anjali, right? She is Indian doctor but based at Dubai, so she has both the numbers, so you can have this her number, right? So that's it. And last slide I did not add it, but we have excellent updated our YouTube channel. So I request each and everyone to subscribe. You will get latest update as well as excellent videos are uploaded on the website, right? So if you see the all the mock test, all the important classes were there, it's uploaded there, and we keep uploading daily classes there as well. So those who wish, they can join the things, right? YouTube channel on the name of Medical MCQ for all. So you just do it. If anybody needs more information, message me. I'll guide you. So now get alert, and your first question starts now. You have at least 15 seconds, not more than 15 seconds in exam. Believe me, overall you have less than 1 minute for one questions in your exam, right? So when you are, I mean, doing the questions, right, in exam, you have less than 1 minute for one questions, believe me. So you need to practice bit hard, practice smart, practice precisely. Random preparation will not going to help you, believe me. I'm not trying to disappoint you, but you need to be very well organized yourself and try to understand the subject, questions and interpretation. So let's see how you score today. I mean, you have your own score in last few. I mean, this is, I mean, in this is month ending March. So far I took 4 multiply by 3. So I almost took 12 mock test, right? In 3 months, there are 12 Sundays. So 12 Sunday I took the class. So you know your score. So you need to improve your score somehow. If you are not improving your score, call me, contact me. We can work out something how you can improve, because you must be something missing. So don't prepare randomly, don't prepare haphazardly. Make a proper timetable, make a proper goal, and start accordingly. So first questions in front of your screen, right? So first question is this, right? 60 years old man present with the GP with the gradual increasing fatigue and some exertional dyspnea. Blood pressure is 118 over 74 and pulse rate is 81 per minute. There are no abnormal physical finding in echocardiogram. Ejection fraction is 47%. However, the clinical impression remains one of the early heart failure. Which of the following circulating biomarker would lend support to the conclusion? Right? Atrial natriuretic peptide, brain natriuretic peptide, endothelium, noradrenaline, and adrenomedulin. So your time starts now. Those who joined the first time in this class, let me tell you, you need three things before knowing the three things. As I called you the triad, the standard triad, you may not get the exact answer. So try to make a practice of knowing the three things for any MCQ. I am every time reinforcing the same thing. You must know the diagnosis of the MCQ, you must know the initial and based investigation, and you must know the treatment, right? So first of all, you need to decide whether they are asking for the some clinical diagnosis, or they are asking in this scenario the investigation, or they are asking the treatment in this scenario. Yes, Ansiya, what's your answer, Ansiya? You can unmute your mic now. It's a open forum, it's a debate, right? So it will, in one MCQ, we try to solve at least 5-10 MCQ in one MCQ. Yes, Ansiya, speak up.
Sir, option B, brain natriuretic peptide.
Fair enough. Excellent. That is the answer. So you are absolutely right. Now tell me, what is the diagnosis in this case? What's the diagnosis? Everything is given there in the class, I mean, the MCQs. So what do you think? What could be the diagnosis of this patient? So diagnosis is congestive heart failure, doctor. They have given here early heart failure. If you don't know, stop me. I'll explain you. Are you agree with me? Yes or no?
Yes, sir.
Congestive heart failure. How do we know? They told that ejection fraction is bit low, 47%. So ejection fraction normal is 50 to 55% is normal ejection fraction. The another is what we called as LVEF, left ventricular ejection fraction. So left ventricular ejection fraction should be roughly 50 to 55 plus is the normal. Higher the better, right? So when the ejection fraction is less, it is a sign of systolic heart failure. In diastolic heart failure, there is a normal ejection fraction, right? But still patient has a symptoms. So who will tell us this is systolic, diastolic, right? By doing the echo, you should know, right? So EF is less. Now see, when there is a heart failure, they have all classical symptoms. So you need to stress, right? Increasing fatigue, this is because of heart failure. Exertional dyspnea, this is the heart failure, right? Blood pressure is this is this. No other physical finding, and echocardiogram is showing this. However, the clinical impression, so they are given the already diagnosis. The clinical impression is, so any patient comes to you, right, with the ideally classical history of hypertension, diabetes, progressive dyspnea, right, on exertion, initially exertion and then at rest, when this ejection fraction will go down 47 to 37, 27, 17, then the dyspnea become worsen because of heart cannot pump the blood, right? And the heart, the fluid gets accumulated and it goes to the lung, pulmonary edema, and very severe cases of heart failure, they present with a pulmonary edema, breathlessness, sputum, isn't it? Yes or no? Right? So this is how they present. So this what, right? So now the diagnosis is confirmed that this is a congestive heart failure. By 2D echo and classical history, you get to know, right? Clinical history, you get to know this is heart failure, right? And now what they are asking, which of the following circulating biomarkers? Circulating means in the blood. Circulating means in the blood. So what blood test would support the diagnosis of congestive heart failure? You understood, Dr. Ansia, what I'm trying to explain? Yes or no?
Yes, sir. Yes, sir.
Right. So what is a brain natriuretic peptide? Can you tell me a little bit more about brain natriuretic? Is it secreted in the brain or it is formed
Sir,
in the brain?
no, sir. It is secreted from the ventricle
Okay.
and it is released in the
Okay.
which is
Go ahead. I
released
will
in the
unmute
blood,
them.
and in the blood which is convert to the stable form, that is NT-proBNP.
Okay. So brain. Then why the name comes brain natriuretic peptide? Is there something special? Just for knowledge, I'm asking. So there is nothing to do with the brain. Then there is a why brain natriuretic peptide. Dr. Yashwini, Dr. Yashwini,
Yes, sir.
any idea why it is brain natriuretic peptide? There must be something, na? There must be something, right? That is why they put the name, right? That is why I'm muting all, because if you want to interact, unmute, because somebody is not understanding. They keep disturbing me. So brain natriuretic peptide, right? Right? Any idea? Any idea? Yashwini, any idea? Why the brain word is there? Okay, no problem. So what is ANP? What is ANP? Dr. Bahar Toprak, what is ANP? Any idea?
Sorry, I have no idea.
No problem. That's fine. It's a learning platform. Wonderful. But I'm at least happy you are interacting with me. Dr. Laru, any idea? Dr. Laru HL. Any idea, doctor?
Sir,
Doctor?
atrial natriuretic peptide.
Yeah, you can speak. No problem. Don't worry about right or wrong. I'm very glad that at least you are interacting with me. So you go ahead. Comfortably, you go ahead. We are not in hurry.
So, promotes the renal sodium and water excretion, vasodilatation.
Okay. So atrial natriuretic peptide, is it released from the atria? Like doctor told, right, that brain natriuretic peptide, that is BNP or pro-BNP, is released from the ventricle. So the name comes from atrial natriuretic peptide. Is it released from the atria? Or what's the importance of ANP? If I do the ANP, or what is the role of ANP in the body? Like BNP, what is the role of BNP in body? What is the role of ANP? So ANP is secreted from where? What is ANP? What does the do ANP in our body? Yes, tell me. They probably not ask BNP, they probably ask ANP as well, na? Right? So I'm trying to cover up a lot of questions. No? I'm trying to cover up many questions. Guru Kumar, Dr. Guru Kumar, any idea, sir?
Sir, no, sir.
No problem. Great, wonderful. So let's see what's the literature. So this is a classical case of, so don't always get a bias that everybody will get the BNP questions. You may get ANP. That is why I'm trying to cover up all the things, right? So this is a classical case of CHF, that is congestive heart failure, as we discussed, by symptoms and by the ejection fraction. All right. And now the test they are asking, which circulating biomarker. So circulating biomarker is BNP, as you correctly said, right? So let's go to the BNP first, right? So BNP is what? Brain natriuretic peptide. Brain natriuretic peptide. So brain natriuretic peptide is considered to have greatest power as a diagnostic biomarker. The given answer in the given answer options. In established heart failure, the high level of endothelium C noradrenaline are associated with poor prognosis, right? So this is not the answer. All of the above answers, including atrial peptidic peptide, except pro-BNP, may also cause the heart failure. But BNP, brain natriuretic peptide test, is the blood test that measures the level of protein called BNP. BNP is brain natriuretic peptide, that is made by your heart, not by the brain and blood vessels. BNP levels are higher than normal when there is a heart failure. So this is one of the most sensitive and specific amongst all what it is given in the things, right? Another interesting story for BNP. This BNP, which also called as a brain type natriuretic peptide, was first described in 1988 after isolation from porcine brain. So what happened? How the story comes as a BNP? So when it was in, right, when the research was done at that time, it is first time isolated from the brain, and that is why people thought it is something coming hormone is from the brain. So that is why the name come brain natriuretic peptide. But what eventually found? It was soon found to originate mainly from the heart and representing a cardiac hormone. So BNP is isolated from the brain initially when it was, I mean, invented, right? That is why they put a name and still the same name is coming, right? It's like aplastic anemia, right? Have you heard of word aplastic anemia? Yes or no? Right? So aplastic anemia, there is never anemia. There is a pancytopenia. So any patient, if you see in the clinical practice, aplastic anemia, so there is not only low hemoglobin, there is also low WBC as well as low platelet. But we are not saying aplastic pancytopenia. For years and years in the book, it's aplastic anemia. So when it invented, it present with the anemia. So we thought, oh, this is anemia, and it is because of bone marrow failure. So it's a aplastic anemia, but it's a aplastic pancytopenia. I can say it's a misnomer. So same way, it's a misnomer, right? So you can say now ventricular natriuretic peptide. Why? Because it is released from the ventricle. It is drawn from the or CNP rather than BNP. It's a CA, cardiac natriuretic peptide. Why? Because it is released from the cardiac, right? So that's all. This is about the BNP. Now let's get back to the other things. What is ANP then? So ANP is a atrial natriuretic peptide. It's a hormone. ANP is a member of family of peptides that have important role, as rightly doctor said, regulating the blood pressure, most prominently through their activities in the kidney to promote excretion of water and sodium. So when you excrete sodium and water, your blood pressure gets under control. So there is a feedback mechanism and there is a regulatory mechanism, right? Sodium secretion or excretion and sodium reabsorption, right? So ANP has a main role in regulating the blood pressure, right? A majority of the ANP is synthesized and secreted by the cardiac muscle, but it has not much role in cardiac failure. Let me tell you, it has role in control of blood pressure. It is clear cut regulating the blood pressure, right? So, but it is also released from the heart. So ANP and BNP. What is the adrenominium? Anyone know? Adrenomedulin. What is adrenomedulin? So adrenomedulin, that is what the option is, right? So if you know, you need to know each and everything in all options. So you know now what is ANP. ANP is a cardiac hormone. It regulates the blood pressure. BNP, it is invented in the brain, but it is released from the heart. So it's now brain natriuretic peptide, right? It's a excellent biomarker or circulating marker for heart failure. So if you want to, right? So say for example, your hospital doesn't have the facility of to deco. Then how do you know the patient has heart failure? So when patient comes to you in emergency room, right, it is extremely sometimes difficult to differentiate between cardiac cause or pulmonary cause, because in cardiac sometimes you have acute massive MI. Patient may or may not have chest pain, right? Patient have the breathlessness, patient have difficulty in breathing. So it's very difficult for you without doing any investigation like ECG, echo, enzyme, right? So only history will not suffice the diagnosis. So if you send simple blood test BNP, so BNP will be normal in acute myocardial infarction, while it would be high in congestive heart failure. So this is how little you can differentiate by the simpler blood test. So ANP, BNP, endothelin, then endothelin. So I want to know what is the endothelin, right? And adrenomedulin. So adrenomedulin is a several functions including vasodilatation, regulation of the hormone, right? And angiogenesis, right? And the antimicrobial activity as well. So adrenomedulin has a lots of activity. What activity? Blood pressure control, once again, angiogenesis, and some kind of antimicrobial activity which kills the E. coli and Staph aureus in a low concentration, for your knowledge. And noradrenaline, as you know, noradrenaline and norepinephrine both are the same thing. Adrenaline is equal to epinephrine, noradrenaline is equal to norepinephrine. No need to confuse. Noradrenaline and norepinephrine is not a different drug, both are the same drug, pronounced differently. If somebody is talking about noradrenaline, means they are talking about norepinephrine. Is that clear? So norepinephrine, also known as a noradrenaline, in both a neurotransmitter and hormone. So he has a dual activity in the brain. It's a neurotransmitter, right, exchanging the information noradrenaline, and it's a hormone as well, and it's released from the adrenal medulla. Adrenaline means adrenal, right? So adrenal gland, adrenaline, noradrenaline, adrenal gland situated just above the renal, both the side, and it plays an important role in fight and flight response. As a medications, norepinephrine is used to increase and maintain the blood pressure. So if you see any protocol, any, if you treat, if you are having a duty in emergency, or if you have duty in the ICU, I mean high definition unit or critical unit, noradrenaline is the most commonly used drug. So whenever any patient comes, either hypovolemic shock, septic shock, cardiac shock, or most of the shock patient present comes, what you give initially is you give the fluid challenge. Fluid challenge is what? You give the bolus, right? Hypovolemic shock or patient comes to you emergency room 80 over 50 blood pressure. What you will give first? You give the fast fluid, either you give the IV fluid, NS, you give fast bolus 500 ml, 1 ml, right? 1000 ml, sorry, you give some plasma expander. Even if it is not improving, then you add the noradrenaline, right? So it is helpful in the maintenance of the blood pressure. So this is extremely important, and this is what the picture I got it from the things. ANP ANP dilates the afferent arterioles, leading to increased blood flow and filtration, and it causes the diuresis. So it helps to regulate the blood pressure. So this is how it works. And ANP suppresses the reabsorption of sodium in the collecting duct and other segments of the nephron, and that is why it is called as a net. Net means Na means sodium, and uresis means passing the sodium from the urine. So net uresis is a function. So it regulates the blood pressure by natriuresis, or excreting the sodium from the urine. So increase excretion of water and sodium, and this is how it reduces the blood pressure, right? So this is how it works. So this is what the excellent diameter I got it from the net. So that's it. This is for the BNP. Anything else? Any doubt? Anybody? Dr. Yashvi, you got the idea?
Yes, sir. Got it, sir.
Is all clear now?
Yes, sir.
Wonderful.
Thank you,
So
sir.
your homework is to read congestive heart failure. I'll ask you,
Yes, sir.
right?
Done,
So
sir.
it is amongst one of the most favorite questions in exam, like acute MI or acute coronary syndrome, heart
Yes, sir.
failure. So heart failure and heart attack both are different things. Heart attack means
Yes,
something wrong in the coronary arteries,
yes.
atherosclerosis, patient die. Heart
Yeah.
failure, coronary is
Cannot
fine,
come.
but because of the heart cannot pump the enough blood to the
Mm,
circulatory system, it gets
right.
failed, and that is called
Yes,
heart
sir.
failure. So don't get confused between heart attack and heart failure. So heart
Yes, sir.
attack is a coronary event, heart failure is a pumping event, usually.
Got
Is
it,
that
sir.
clear? So you
Yes,
need
sir.
to read completely heart failure. What is heart failure? What are the type of heart failure, like systolic heart failure, diastolic heart failure, how you differentiate, how they present, how you diagnose, and what the treatment. Is that
Got
clear?
it, sir.
So
Yes, sir.
yes, you have any idea that if the same patient comes to you and if they ask the treatment, so now they ask, now I'll further go ahead with this question, right? So what the
Yes, sir.
question, right? They have done the circulating biomarkers and they found a very high BNP in the blood or the serum. What is the treatment of choice? This is the another questions. So what do you think? What will you give to this patient when comes to you with a heart failure in your OPD or emergency? What could
Sir,
be whatever in your mind? Tell me. Don't worry about right or wrong. It's a debate platform. So if you speak more, you learn more. That's it.
sir, we avoid all fluid overload. There is supportive care,
Okay.
and
So first of all, let me understand your concept. So you avoid the fluid overload. Fair enough. Okay. So you instructed to the doctor or your junior doctor in emergency. Okay, don't overload her with the fluid because it's already in the failure. Okay.
hmm,
Now to reduce the failure, what will you do?
the patient will be symptomatically, a patient will be on medications or ACE inhibitors, antihypertensives are given,
Patient
sir.
patient is on hypertensive, not mentioned here, but say for example, this patient is hypertensive. He is taking
Yes,
antihypertensive drug, and if you
yes,
can see at the vitals, I had already mentioned in the scenario. So this is looks like a stable, right?
yes,
180 over 70. Pulse rate is also fine, 81, so not bad, right? Not
yes,
bad.
yes,
So in
yes,
that case, what you want to do now? What the medication? So if I can write down the list of the treatment, say for example, treatment, no IV fluid or no fluid overload. That's it.
yes,
This is one treatment. Okay, fine.
yes, yes,
But stopping the fluid does not cure the symptoms, na?
yes,
Right?
yes,
If you don't give any fluid, then
mm,
exertion will not go away. Dyspnea
right,
will not
sir.
go away. Pumping will not come up from 47 to 57. You need to do something, isn't it? What will
Yes,
you
sir.
do?
So diuretics and ACE inhibitors.
Excellent. Wonderful. Diuretics. Why you want to give the diuretics? What the diuretics does? Why you want to give the diuretic? What diuretic does? And name the diuretic. Three questions.
So prevent overloading or prevent the fluid accumulation.
No, it will not prevent. The name itself says diuretic, right?
Mm,
Or you can call it as a water pills, or it will increases the, right, or it will increases the urination basically. So the
yes,
name is a furosemide.
yes, sir.
Have you heard the furosemide,
Yes, sir.
right?
Yes, sir.
Diator. These are the few
Yes,
drugs,
right.
right, which acts on the collecting tubules,
Yes, sir.
right, try to increase the urine output. And when you increase the urine output, you are making a negative balance, right? Patient has lots of fluid in the body. So now if you give the diuretic, fluid will go out of the body, pulmonary vessels may open up, right, and patient has
Yes,
a better symptomatic improvement, and
yes,
oxygen inhalations as well. Oxygen inhalation. So these are the two initial treatment. You give this oxygen support to the patient. Patient is asymptomatic, right? And
right.
you increase, you give the diuretic. Once the patient gets stable, and this diuretic could be in the very high dose,
Mm.
make the patients very negative, very high dose. If you give, right, probably 6 or 80 milligrams of furosemide, 200 milligrams of furosemide, right, around 4 to 5 ampoules stat, if you give, patient becomes dry, lots of urination. Probably you need to do a catheterization as well, right? Because patient may urge every 1 hour early, too early, he wants to pass the urine. You understand? Just and catheter may probably check the exact urine output, right? So urine output will increase, and this is how it works. The diuretic is the drug of choice, and then after that you need to treat long term. Once patient is stable, you discharge the patient at home, and now that's the homework. What drug medication can be used for the prevention of cardiac failure or to delay the episode of cardiac failure? You use as inhibitor, beta blocker, calcium channel blocker, digoxin, diuretics, blah blah. There are long list of ABCD drug. So I want you to read properly 110% in cardiac. If they want to ask any question, it's cardiac failure, it's acute coronary syndrome, it's infective
Yes, sir.
endocarditis, right? These are the hot favorite questions in any exam.
Right, sir.
That's all. Is that clear to everyone? Yes or no?
Yes, sir.
Dr. N, is that
Yes,
clear?
sir.
Dr. Ansia, is
Yes,
that
sir.
fine?
Yes,
Wonderful.
sir.
Wonderful. Wonderful. So everyone, not just the Yashwini, those who have little weak in cardiac failure, also this is homework for you. So 1 out of 0 is not a good score. I will remind you every questions before. 1 out of 1 is a good score. So you got 100% so far, right? So check your own score. I won't ask you personally and I'll call you after lecture, oh, how much is your score, doctor? But you need to assess yourself, and that is why we are doing so much of hard work on every Sunday. Rather than sleeping and resting whole the day, I'm preparing whole the week just to make it more interactive and more informative. So let's switch to the next questions. You have 30 seconds. A 63-year-old African American man with no past history present with the recent increase in prostate specific antigen from 2.2 to 4.3. Digital rectal examination reveals 0.5 centimeter nodule on the left lobe of prostate. Which of the following is the most appropriate next step in the evaluation of the patient? CT scan of the bone scan, prostate biopsy, radical prostatectomy, treat with 7 days of antibiotic, recheck the PSA level in 3 months, and urinalysis. Post your answer. Read it well. I'm not in hurry. 15 seconds. Don't be in hurry as well. But try to understand the questions. Try to understand my triangle. What is the diagnosis? How you investigate? How you treat? Right? So we are almost 30 plus people on Sunday morning, but answer is only 3, 4. Yes, Monica Gupta. What's your answer?
Yes, good morning, sir.
Very good morning, doctor. How are you doing today?
I'm fine, sir.
Wonderful. Nice to hear from you. It's
I think,
pleasure.
sir, 7-day course of antibiotic will be first step.
Okay,
Then
fine.
we'll be taking prostate
Fine,
specific.
fine. So you and me will discuss for 2 more minutes if you are agreed with me.
Yes, sir.
Wonderful, wonderful. You are a brilliant lady. So now what's the diagnosis in this patient?
There's a prostatic, recent increase in prostatic specific, query prostatic carcinoma.
Excellent, excellent, very excellent. Query prostate CA. CA prostate means carcinoma, prostate. Okay, fine.
Yes.
That is query. That is absolutely perfect answer because we did not did the biopsy, so it's query. Okay, fine. So what if there is a prostatic CA, if you are suspecting any patient with a prostatic CA, what test you will do? Extremely important in hemato-oncology. Oncology, this question will absolutely asking in every exam. Prostate CA.
Sir, prostatic biopsy.
Okay, so prostatic biopsy. So directly you go for the prostatic biopsy or anything else you will do before doing the biopsy. So if any patient comes to you with urinary complaint, you tell them, okay, now come to my OPD, I'll do biopsy.
No,
Is it
sir,
the way?
go for the investigation, go for the
Which is,
CT scan.
yeah, so tell
bone
me
scan.
that list now. You tell me the list. So patient comes to you by
Yes.
history and by some details given here, you suspecting this is a prostatic carcinoma. So forget about this scenario. If you suspect any patient of a prostatic carcinoma, what investigation you will do?
Sir, CT scan and bone scan.
Okay, CT scan of which part? Chest, head and neck,
CT scan, kidney, urinary, bladder, prostate.
KUB. So you mean to say KUB, kidney, urinary bladder and prostate. Okay,
And
fine. So CT scan, one CT scan. What else you want to do, or it's enough, good enough?
the urine analysis.
Okay, urine analysis. Now tell me why you want to do the urine analysis in a prostate cancer.
Sir, rule out any albuminuria, whatever.
So do you think that albuminuria can be caused by the prostate cancer?
No, sir, not prostate cancer.
Because you are suspecting prostate cancer, na? In this patient, you are
Yes.
suspecting prostate cancer. Okay, fine. Then if the albumin you want to see or you want to do something with urine, then why you did not selected the urine analysis then? Why you directly want to jump on the direct antibiotic without doing? If the urine is sterile, if the urine there is no pus, no nitric nitrates present, there is no WBC in the urine, then still you want to give the antibiotic to the patient?
If there's no UTI, then it might be prostatic inflammation since it's showing the 0.5 centimeter nodule.
Okay, so 0.5 centimeter nodule in 63 years of old African-American man, what it indicates?
Can be prostatitis may lead to
Prostatitis. Okay, so what are the symptoms of prostatitis now?
that is pain and inflammation.
Pain and inflammation. So do you see any kind of pain?
There's no past medical history, the question is saying, but there's a recent increase in PSA.
Oh, so why the recent increase in PSA then? What
And
could
then
be, what are the causes which increases the PSA now?
the early diagnosis, early stage of CA prostate.
Okay, so there are only one reason in this world which increases the PSA, only prostate cancer.
Yes, sir.
Tell anyone, open, tell anyone.
BPH.
BPH, okay, fine. So wonderful. So let me rather bifurcate in a two way, the benign cause, right, and malignant cause, right? Is that
Yes.
clear? So benign means what? It's a non-cancerous. So benign and malignant. So malignant is obviously CA prostate, you may increase the PSA. So what are the benign causes? So one is a BPH, benign prostatic hypertrophy or hyperplasia. Another is a prostatitis, inflammation of prostate. Third thing is a digital rectal examination. Even after doing the digital rectal examination, you have the increase. Even after doing the biopsy from the prostate, right? If you do the PSA, whenever prostate manipulates either digitally or by some instrument or by some needle or by something, it will increase. Is that clear? Right?
Yes.
So there are not always a reason only in only cancer that you increases the PSA, right? Rather, let me tell you, most of the PSA increase because of the benign condition. Rarely you get pressure. So if I see in my OPD, being a medical oncologist, if I see 100 patients per year of increased PSA, they present with increased PSA, 80 to 90% are BPH, benign prostatic hyperplasia. Only 5-10% people out of 110 or 20 will have a prostate cancer, right? So I should not miss the benign as well, right?
Yes.
What's my goal is not to miss the malignancy, because malignancy is a deadly. Benign is not deadly. BPH patient will not die, but malignant, it will die, right? If you don't do it, it will infiltrate, it will spread up and down and side by side, and it will cause the obstructive uropathy, right? So this is what the thing is. Dr. Sami, if you don't mind, can you explain why you selected CT scan and bone scan, Dr. Sami? Just I want to understand your logic, why you want to do the CT scan and bone scan. Are you there, Dr. Sami, in the class?
Yes, sir.
Yeah, please, Dr. Sami. Speak up, don't worry. It's an open
So,
platform.
because there is a nodule, and the patient is old age, like 63 years old.
That's correct.
So, thinking of the CA, I select the CT scan so that we can see if there is any malignancy or something.
But isn't it a good enough, the data, the digital rectal examination is clear cut showing the nodules on the left lobe of prostate? So something wrong in the prostate, isn't it?
Yeah, but I was thinking like it could be metastasis or something.
Okay,
So
so
to rule out that.
okay,
Mm,
fair enough. Absolutely perfect. But I want to
mm,
understand,
mm.
are you going to do a patient's workup without doing a biopsy? So say for
Yeah,
example,
yes, I think.
this patient,
Mm,
say for example, biopsy is a negative or there is a no cancer. Still you want to do CT scan and bone scan both? If it is turned to be, I so say for example, this patient comes to me, I am thinking that this is a query prostate CA. I now want to confirm. Strong history is what? 63 years. Let me tell you, these are the very, very important point which you usually we miss in our clinical history or something, right? So don't, everything is important in scenario. So 63 years, right? Prostate chances is high, right? Recent increase in prostate. So 2.2 to 4.3. So recent increase, something alarming. So one factor is age, one factor is increased PSA. Second thing, third thing is a nodularity on DRE. DRE is a digital rectal examination. It is mandatory, right?
yes,
And where you find the 0.5 centimeter nodule on the left lobe of prostate. So my impression is now strong. Elderly male, increasing PSA, absolutely nodularity on the digital rectal examination. It could be prostate CA, and when there is a query prostate CA, you need to confirm, query to confirm, and query to confirm is the biopsy. Query to
mm,
confirm is the biopsy. And once you do the biopsy, and if it is a positive adenocarcinoma of prostate, the commonest pathology, another question in your exam, which is the most common pathology or histopathology in the prostate cancer? Adenocarcinoma. So adenocarcinoma, you can mute now if you're not interacting. Something is disturbing from behind. So adenocarcinoma is a biopsy. And once the biopsy is done, then you need to do next thing is a staging. Which stage of this cancer is it? Isn't it, doctor Sami?
yes,
You want to
yeah,
do
right.
staging, and staging you can do the CT scan. Let me tell you, MRI is better, but as per the scenario, it is CT. I'm telling CT. Otherwise, MRI and bone scan is the one of the best tool to stage the disease. And if the bone metastasis is present, it is a stage 4 metastatic prostate cancer. Start from the prostate and match to the bone. That's it. That's clear, right? So
Right.
any patient, not this patient, prostate cancer, lung cancer, breast cancer, colon cancer, any cancer, any solid tumor, right? Cervical cancer, ovarian cancer, uterus cancer, vulval cancer, right? Any cancer, any sarcoma, right? Before diagnosis, it's not a good idea to do the staging workup. So staging workup is mandatory, absolutely mandatory, but that comes after the diagnosis, right? If this patient has a benign things or prostate biopsy, I may not go for bone scan. Na? Why should I want to do the bone scan when I'm not thinking? I confirm with the biopsy that this is not a malignancy. It's a waste of time. It's over investigation. It is a physical mental trauma to the patient to doing a lot of tests and he's scared, right? If I tell you lots of long list of tests, probably you will scared, na? Why doctor is advising me so much of long exhaustive list of the investigation, isn't it? Yes or no? Right? So
Right, sir. But sometimes, like when we do this procedure type of things,
yes,
like any small procedure, even, so before for a patient satisfaction here, like we go for a CT and then like we do biopsy.
fair enough. So you go and read the literature once again, right? I
Yes,
don't
sir.
want to disappoint you. You are absolutely right. But our role is not to just make the patients feel happy. Whatever we are discussing here is evidence based. So if you go and open up the book, high PSA, what they will do the digital rectal examination. They did already. Another important investigation is a transrectal ultrasound. Have you heard of TRUS, TRUS, transrectal ultrasound?
Yes, yes,
Trust,
sir.
TRUS, transrectal. So once this is even better. So first what you do the digital rectal examination. Something wrong in digital, then trust, transrectal ultrasound. If you find nodularity 0.5 centimeter on ultrasound, then you do the transrectal prostate biopsy. Transrectal prostate biopsy, because from the rectum, just behind the rectum, there is a prostate, very easily accessible. And once you do the transrectal prostate biopsy, you confirm that it is a now not suspected, it is a confirmed case of CA prostate, right? Adenocarcinoma prostate. Then you go for the staging workup. And nowadays there are PSMA scan. If you know somebody who is working in oncology, PSMA scan, if PSMA PET scan, PSMA PET scan is there latest the test for PSA, I mean for prostate cancer. But if you don't have this, then you go for MRI abdomen pelvis plus bone scan, right? Because
Okay, sir.
prostate malignancy first spread to the bone. So before operation, why it is important? Because if it is a localized disease, then treatment, then now how you treat these patients, sir? So if the MRI is normal, bone scan is normal, right? It is not spreaded out of the prostate, then treatment of choice is a radical prostatectomy. Have you heard of this word, radical prostatectomy? Yes or no?
I
Anyone?
heard about it. Yeah.
Anyone heard about it? Yes or no,
Yeah.
brother?
Yes, sir.
Wonderful.
Yes, sir.
So radical prostatectomy, in which complete prostate is removed, right? And patient can be offered a curative treatment. So CT scan is not the first choice now. Prostate biopsy is the answer. Until and unless prostate biopsy comes right positive, it is absolutely a horrible idea to go for prostatectomy, because if you do radical surgery, major surgery, and you find, oh, now this is not a cancer, so it's a trouble, right? So if you have no heart attack and somebody did the angiography and angioplasty, it's a horrible, because you're open, your coronary is open, then why you want to put a stent? If it is blocked, then you put a stent, na? Then if you have cancer, then you do the radical prostatectomy, right? Otherwise not. Antibiotic has absolutely no role, because we are not thinking it is prostatitis, no pain, nothing there, right? Elderly male, nodularity, and in prostatitis, Dr. Monica, you can't see a nodularity in prostatitis. Prostatitis is just the inflammation of the prostate, infection of the prostate, right? So it is a important thing in prostatitis. If this scenario is prostatitis, two things must be there. One is a pain, or tender on touch, tender, right? When somebody palpate or digital rectal examination, they will not allow too much of pain, right? So pain or tenderness is there, plus, and there is a bacteriuria, UTI is also there, UTI, right? And here you have to give long antibiotic, not just 5-6 days. Some literature shows there is antibiotic for 6 weeks, right? Prostatitis, because it's difficult to penetrate to the prostate oral medication, right? So you have to give a long course. Is that clear to everyone? Dr. Yash, Dr. N, Dr. Toprak, any question?
Thank you, sir. So thank you so much.
Yeah, I know.
Okay, great. Any questions? Any random questions? It's fine. I mean, don't worry about asking the questions right, wrong, silly, non-silly. Don't worry. You won't get better than this opportunity the way I'm trying to get the answer, right? So I try my level best to make all the pros and cons of the prostate cancer. So again, your homework is to read the prostate cancer. 100% hemato-oncology. Favorite question is breast cancer, cervix cancer, colon cancer, and prostate cancer. So they can ask anything. PSA is a hot favorite in USMLE and all PROMETRIC. Third questions, very, very easy. But if you see the number, you feel, oh my God, this is complicated. We never heard of this. ABG, what are the numbers? Oh my God. So it's very toxic questions, sir, putting every time. So this is not toxic questions. After my explanation, easy question. But until and unless you know the ABG, you feel little tricky. 2 out of 2 is 100% good score. 2 out of 1, 50% score. 2 out of 0, 0% score, not good score. 2 out of 0 is very bad score, sorry to say. 1 is okay. 2 by 2 is excellent. Let's see. 3, you are informed that one of your ward patient has been breathless over the last hour and has been quite anxious since her relatives are left after visiting. The patient is 67-year-old woman who was admitted 6 days ago for the left basal pneumonia, which was responded well with intravenous antibiotics. Her past medical history includes dementia and hypertension. You are asked by your registrar to interpret the patient's ABG measurement taken during the tachypnea. pH 7.49 into bracket, given the range, kPa PO2 14.1, PCO3 is 3.1, kPa HCO3 24, and from the list of the answers below, choose the most appropriate ABG, that is arterial blood gas. There are 3 terminology. ABG is arterial blood gas, right? VBG is a venous blood gas, and CBG is a capillary blood gas. So most of the time in emergency, we do the ABG, arterial blood gas, right? So you interpret this, what it looks to you, and what's your thought process of ABG.
Yeah.
I need the explanation, not just the ABCD.
Sir, it is because due to hyperventilation, because the patient
So
is
who is
very
speaking?
active.
Sorry, first of all,
Sir,
your
I'm Dr.
name.
Guru Kumar.
Yes, Guru Kumar. Sorry. Yes, tell me. Go ahead now.
Sir,
So what's the
the patient
diagnosis? First of all, sorry. I mean,
respiratory oncology, sir.
sorry, just our more learning. I'm interested in learning, not in mugging up. So what's the diagnosis? Tentative, possible, so-called. What's the diagnosis?
Sir, respiratory alkalosis due to hyperventilation.
Hyperventilation. Right.
Pneumonia.
So basically, this patient has a pneumonia, right? Diagnosis
Pneumonia.
is basically pneumonia, right?
Yes, sir. Okay.
Respiratory alkalosis, acidosis, blah, blah, blah. It's a finding. It's not a diagnosis, right? Anemia is a finding, not the diagnosis, right? Diagnosis is anemia secondary to iron deficiency is a diagnosis. Anemia secondary to aplastic anemia is a diagnosis. So
Yes,
respiratory acidosis, alkalosis, blah, blah, secondary to pneumonia. So primary
pneumonia.
diagnosis is pneumonia. Fair enough.
Pneumonia.
In pneumonia, you will do the chest X-ray in general, right? Chest
Yes,
X-ray
sir.
you will do, right? It's a basic. Another thing is you do the basic blood workup and electrolyte and blah blah things, and you must do ABG, and you check the oxygen saturation by pulse oximeter. So any patient, breathlessness patients comes to your OPD, mug up fix in your head, you cannot avoid chest X-ray. You must do the chest X-ray. You must do the basic blood test, because in blood test you find that there are total WBC count is 20,000. It's high. It's a infective pneumonia. So that give you the idea. By ABG you get to know what's the things you need to treat, and you need to see the oxygen saturation. If it is low, you need to administer the oxygen inhalation by nasal punch or bag and mask, whatever depends on O2. So any patient, forget about this scenario. Any patient comes to your OPD, IPD, indoor, ICU, MICU, wherever, patient is breathlessness, no need to call intensivist. You are a doctor, no need to call intensivist. You just do some simple blood test. You do X-ray, try to find out what's wrong. All right. Sudden breathlessness, it could be a pulmonary embolism, it could be a heart failure, it could be a severe MI, it could be a cardiac arrest, it could be a severe anemia, right? It could be a interstitial pulmonary fibrosis, it could be a ARDS. There are long list of breathlessness. So by doing
Yes.
the basic investigation, you get to know that, okay, fine, I'm dealing with this, sir. It's okay, right? So you do the chest X-ray, you do the blood test. This is the basic tip, not with this scenario, but you need to keep in mind. It's very important and we forget, right? We are concentrating on antibiotic, but when the SpO2 oxygen saturation is 80, we forget to give the oxygen. And if you don't give the oxygen to the hypoxic patient, you are doing the more injury, or you are giving the more ischemic injury to the various tissues in the body, isn't it? Fine.
Yes,
So
sir.
it's all done. So now this is the picture with this. So what's your answer now? So you interpreted this patient has a pneumonia. So this patient is a pneumonia. Patient has a hypertension and dementia. Patient received already intravenous antibiotic, right? And the patient anxious and pneumonia response there is antibiotic. Hypertension, you are as registered, right? Okay, fine. So now breathlessness. Now what's the complaint? He has a pneumonia. You treated breathlessness over the last hour. Means what? Last 1 hour patient has a breathlessness. He has a pneumonia. He received antibiotic. While he had breathlessness, you tell someone, technician, right, in the lab that, okay, gentlemen, come and collect the ABG. Now they come and collect the ABG at the time of breathlessness, and this is the ABG. Now you go ahead further.
Sir, in ABG, pH is increased, sir.
Okay, so what is the normal pH?
pH is 7.35 to 7.45.
1 minute, brother. pH is 7.35 to 7.45 is a normal, right?
Yes,
So
sir.
if it is a low, what it is called? If it is high, what it
Acidosis.
is called? So when it is a low, it is a acidosis. Acidosis. If it is high, it is alkalosis. So first of all, what is the here? 7.45 is high or low? First of all, decide.
Alkalosis.
High
High. High.
or low or high? high. So if
High.
it is more than 7.5, it is what is the diagnosis primarily?
Alkalosis.
So first of all, forget about everything. You remove this, there is no alkalosis. Acidosis, you remove it, none of this, remove it. Now you are confusion, what? Respiratory or metabolic? Now your job is little easy, right? You have to struggle between metabolic and respiratory. So how do you decide now? This is metabolic, this is a respiratory. Yes, doctor.
CO2 is important.
Sorry, CO2 is important.
CO2
corresponds to respiratory, sir.
is
Sorry?
another.
Yeah, so classical histories correspond to the respiratory, right? So this could be a respiratory acidosis, right? Not the metabolic acidosis. And when there is a respiratory acid alkalosis, sorry, the compensatory is a metabolic acidosis, isn't it? There is a
Yes.
compensatory mechanism. Is that clear? Right? So now this is a very simple diagram. I will share the PowerPoint, don't worry. I will make very easy for you now. Very easy. Yesterday, Maddie took brilliant lecture on ABG, I guess. Right. So I'm trying my level best to make the more this things. So pH, right? pH is 7.35 to 45. If it is less, it is acidosis. If it is more, alkalosis. So any ABG interpretation comes in your exam. First and foremost, your step, number one step is this. Don't worried about what they ask in the scenario, whatever the scenario is given, whatever the complicated things they are given. Whenever anything comes to the ABG interpretation, your first thing is to look at the ABG. Is that clear to everyone? Yes or no? Please tell yes or no.
Yes, sir.
Right? In pH, what you have to see? You don't need to apply brain. You have to see in how much is the pH, right? Less than 7.35, acidosis. More than 77.45, alkalosis. So this is alkalosis for our case, right? Once this thing is decided, acidosis or alkalosis, you decided that, okay, sir, it is alkalosis. Why? Because the pH is high. Is that clear so far? Yes or no? If you don't understand now, I'm trying my level best to make it absolutely understandable. Otherwise, very complicated. So alkalosis. Now, after alkalosis, you look at the CO2, PCO2. The very important thing is here, I remember in this way, this is 35, this is also 35, this is 45, this is also 45. So now job is easy. Now job is easy. 7.35 to 7.45 is pH, but 35 to 45 is a arterial carbon dioxide, PA. Arterial pressure of CO2. A is arterial, P means pressure, CO2 means CO2 gas. Carbon, C for carbon, two atoms of oxide is oxide. So arterial pressure of carbon dioxide. Is that clear? Yes or no? Yes
Clear.
or no? Right, clear.
Yes,
Wonderful. So now what's the job? 35 to 45. Right here, 35 to 45. So if it is a 35 to 45, if it is more than 45, it is a acidosis. And if it is a less than 35, it is a alkalosis. Right? Right? So you need to see that as well. Second, right? Whenever there is a respiratory event, they had given likely a respiratory event, respiratory acidosis, respiratory alkalosis. When so you get a GI scenario, 35-year male presented with lots of vomiting, blah, 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 this, that, diarrhea, vomiting, electrolyte disturbance, something metabolic. Got it? So just don't get a very overactive brain. Just think what the scenario is saying, right? So here, the more than 45, it's acidosis, less than 35 is alkalosis. And just look at the third thing. We don't need to see lots of things in this. 22 to 26 is sodium bicarbonate, right? It is a 22 to 26 normal. If it is right here, the high is acidosis, here high is alkalosis, and low is acidosis. Simple. Get to this picture, bit normal, right? Remember this picture very easily. I got it by a lot of exercise from the net. Again, trying to clear your concept. Three things you need to see. First of all, whenever any ABG comes, first pH, look at the 75 to 35. If it is less, it is acidosis. If it is high, means going beyond 7.45, alkalosis. Is that clear? Now see,
Yes.
35, 45. If it is a CO2 is high, means CO2 retention, what we call as a CO2. So whenever there is an extra CO2 in the body, it produces acidosis, respiratory acidosis, right? Like a chronic asthma, COPD, where there is a CO2 retention, CO2 narcosis, right? Blah blah, whatever we heard. Type 2 respiratory failure. Type 1 there is a hypoxia, right? Low oxygen. Type 2 is hypercapnia. It's type 2, right? So I'll give you homework, don't worry. So when there is a low pH, it is acidosis, high pH alkalosis. Same way, high CO2 is acidosis, low CO2 is alkalosis. And reverse the things, low soda bicarb is acidosis, this is high soda bicarb is alkalosis. Here high is acidosis, CO2 high is acidosis, and HCO3 high is alkalosis. Simple. No need to mug up. No need to mug up. So now your job is easy. You just need to three parameters: pH, PCO2, soda bicarb. That's it. Any ABG you can interpret very easily. If you know the things, simple things, you know the things, right? This is a normal chart. You don't need to mug up whole the chart. You need to remember only three things: pH, right? PaCO2 and soda bicarb. HCO3, sodium bicarbonate. That's it, right? So this is what the thing is. Now go back to the scenario. Go back to this scenario. What the scenario is saying: pH alkalosis, right? Here they have given little PCO2, little complicated in Ka, right? In Ka, this is a respiratory things, right? So alkalosis, respiratory alkalosis. I think there are 3 or 4 excellent MCQ in the Master the Body USMLE, right? So you go and read it. You go and read it. That will give you homework. Homework. Write down the homework. What is type 1 respiratory failure? What is type 2 respiratory failure? Anyone knows what is type 1, type 2 respiratory failure? And condition associated with it, both.
Is acute respiratory distress syndrome.
Okay, so what you are, telling about type 1 is what? What is the definition of type 1? When you say this is, when you say that, oh, sir, this is respiratory failure type 1, so what? There must be some definition. Na? If this criteria match, it is called, sir, respiratory failure type 1. And if this criteria match, this is respiratory failure type 2. So if you don't know, don't waste the time. Go and read it. Extremely important questions, frequently asked in questions. So your homework in respiratory today for now is to again read the whole chapter of ABG. It's a small 2-page chapter, not very big. I told you the bottom line and crux of the story, but you need to read, again clarify. There are 4-5 again questions. If you solve that questions with explanation, again you get better idea. We'll again discuss, we'll again try to evaluate. But this is the basic things I told you. We are usually, I'm seeing 10 out of 9 student, 9 out of 10, sorry, 9 out of 10 students are avoiding these questions. They don't want to do the ABG. They don't want to do, but you do it. You try to work hard. It will come in the exam for sure. 3 out of 3 is 100%, 3 out of 2 is 66%, 3 out of 1 is 33%, and 3 out of 0 is a 0%. So you decide your score. 4. A 32-year man comes to the clinic with a multiple vesicle on his penis. There is an enlarged adenopathy in inguinal region or areas. What is the next step in the management? Are you going to do a T-zinc preparation? Viral culture, because looks like a viral. You will well cyclovir and you will give when gencyclovir. I'm not putting every time very difficult question. So don't scared. Give your natural answer. Yes, Dr. Toprak, any comment?
Yeah.
What's
I
the
think
diagnosis? What's the diagnosis? First, we go to the diagnosis.
is HSV.
Diagnosis is what?
Herpes simplex virus.
Sorry?
Herpes simplex virus.
Okay, great. So HSV, herpes simplex virus. Fair enough.
Yeah. And we shouldn't waste time because probably he feel too much pain, and we pass suddenly treatment, and it is aceclover or slower.
Okay. So what is a T-Zank preparation? What is T-Zank preparation in HSV? Do you know that T-Zank preparation?
Python biopsy.
Sorry?
I'm not sure, but maybe it is a kind of biopsy.
Okay, fair enough. So you go and read it, T-Zank preparation. They ask sometime this, right? What's the viral culture? What's the valcyclovir? What is valganciclovir, Toprak? Valganciclovir is what? Is it drug or what?
Pneumodrug, sir.
I didn't hear it.
Okay. So again, you go and read. It is given in Master the Board, right? Antibiotic chapter or antiviral. Vir means viral. Vir means viral. Anywhere when vir come, think that it is virus. Acyclovir, valcyclovir, valganciclovir. So vir is a virus. So anyway, so anyone knows what is a valganciclovir? Is an exam drug. I mean question. Anyone open? Valganciclovir. Can anyone tell me what is a valganciclovir? It is antibacterial, antiviral, antifungal, antiprotozoal, antiviral. Antiviral. Are you sure? Which disease you give and valganciclovir? Which virus? It's active against which virus? Is it the same HSV or some other different virus?
CMV.
Sorry?
Cytomegalovirus, sir.
Excellent, excellent, excellent. CMV, not HSV, CMV, right? So don't get confused, right? So this is a classical case. This is the penis, right? As this is, I took it from the book, right? So this is a classical picture presentation. This is a glans penis. This is the multiple vesicle, right? Or herpetic vesicle, right? Classical case of herpes, right? What it could be, herpes type 1 or type 2? If there is a genital vesicle, it is type 1 or type 2, and it is a oral vesicles is type 1 or 2.
Type 2.
Sorry. So this is homework. This is homework. How you differentiate herpes simplex virus type 1, type 2. Homework. Write down. It's important. Exam question. Right. So I cannot finish it off everything in just 2 hours. So that's little homework. And this all is I'm telling is recall. Believe me, I am doing more reading than you, though I am not going to go for any exam, but still I'm reading more because I want to coach you. And when I want to coach you, I want more reading than you. Then I can explain well, right? So go and read type 1 versus type 2 herpes simplex. Write down, right? Otherwise you will forget. So this is a classical case. Now see the literature. The answer is valcyclovir. Why valcyclovir? When there are clear vesicle lesions noted, right? When there are clear vesicle lesions are noted, right? What you need to do, right? There is no need of doing any diagnostic test. It is clear cut, absolutely penile, vesicle, clear cut, visually diagnosis, right? And patient is asymptomatic. I mean, patient is symptomatic, clear cut case. Directly jump on the treatment, right? So for the herpes, if the questions describe multiple vesicle and treatment with acyclovir, valcyclovir, and famciclovir, not valganciclovir is not in the treatment of herpes, genital herpes. Again, let me remind you, acyclovir is old is gold, the drug, right? Acyclovir and then valcyclovir. So they have not mentioned here acyclovir. So our answer is valcyclovir. If acyclovir and valcyclovir is not mentioned, they mention famciclovir, famciclovir. Then answer is a famciclovir, not valganciclovir, right? T-Zank preparation. Daily suppressive therapy can be prescribed for recurrent genital herpes. If the roof comes off the vesicle and the lesion becomes an ulcer of unclear etiology, then the best initial diagnostic test is T-Zank's preparation, Dr. Toprak. So when there is a classical vesicle, you start jump on the treatment antiviral, but patient may present bit late, right? The time of the vesicle gone. Now they present with the ulcer. You don't know it is a syphilitic ulcer. You don't know some other ulcer. You don't know whether it is a other sexual transmitted disease or it is a herpes. Then you go for the biopsy or then you go a diagnostic test that called as a T-Zang preparation. But I want you to know what is exactly T-Zang preparation and how it does, right? How T-Zang preparation is prepared, how it's done, how the swab is taken, from where the swab is taken. So go and read it, everyone. The most accurate test for herpes is a virus culture. But let me tell you, it's a costlier affair, it's a time consuming affair, it is not available everywhere. So just give the simple acyclovir for 7 to 10 days, give valcyclovir for 7 to 10 days. If it is not subsided, if patient not get the cure after 10 days, and if still persistent and you doubting now on your diagnosis of herpes, then you go for the viral culture. Nobody does in my practice. I have infectious disease specialist in my team in my hospital. We ask many a times, sir, we are not doing it. If it is something not responding to drug, then second line we do viral culture. Like COVID virus, we never did the viral culture for COVID. We did just what we did in COVID is we do some blood test, CRP, we did CT scan, that's it. We never did the viral culture for COVID-19. Same way, we directly started the treatment doxycycline, azithromycin, blah, blah, that's it. So when there is a case classical, no need to do any culture. You just jump the treatment. Valganciclovir is a treatment or therapy for cytomegalovirus, CMV, and this CMV in HIV is very important. It causes CMV pneumonitis. Two major medical manifestation of CMV in clinical practice is CMV pneumonitis, especially in HIV. When the CD20, I mean CD4, CD8 count is less than 200, you get this, and another is a CMV retinitis, retina or retina, the infection and inflammation with the CMV is CMV retinitis, and in this case you need to give valganciclovir. Don't get confused with valcyclovir. So gan is additional word. Patient with the frequent recurrence should be placed on chronic suppressive therapy. Acyclovir resistant herpes is treated with a foscarnet. So this is a newer drug, comes in the market as a new player, but keep in mind that's it. 4 out of 4, tremendous score. 4 out of 3, 75%. 4 out of 2 is 50%. 4 out of 1 is 25%. 0 is 0%. Check your score. All okay? So far all okay? Yes or no? Be with me.
Yes, sir. Yes, sir.
Yes, sir.
Going well overall? Going well so far so good?
Going good, sir.
Yes.
Wonderful.
Yes, sir. Good, sir.
Wonderful, wonderful. I got fortunately a brilliant team. Wonderful. Next, I'm unstoppable in MCQ, believe me. I can speak for 6 hours. An old man comes to the doctor complaining that a part of this body is rotten and he wants to remove it. What is the most likely diagnosis? Psychiatric questions. I try to compile psychiatric questions, GI questions, viral questions, right? Surgical questions, gynec questions, all will come. So is it guilt feeling? Is it hypochondriasis? Is it Munchausen syndrome? Is it nihilism? It is Capgras syndrome. Give one example of all conditions mentioned above. Your time starts. Yes, Dr. Onkar. Any comments, sir? Dr. Onkar Nath Thakur. If you are in the class, I would be happy. Yes, Saima Malik. Welcome on this board. No comment.
They're extremely very difficult questions, sir. Means I'm still confused.
हम हर
Definitely
बार
that it's not me.
sorry to
It's not
speak in
me at all.
sorry to speak in Hindi, but हर बार हम एकदम लॉलीपॉप क्वेश्चंस तो
नहीं
नहीं कर
दे
सकते.
सकते. So you are a great teacher, sir.
Yeah,
You are
तो
a great
एग्जाम में तो ऐसा नहीं होगा ना, एकदम लॉलीपॉप
बिल्कुल
सिंपल.
सही सर, लेकिन actually I have not heard these terminologies, so I cannot comment. I know hypochondriasis. Definitely, it's not that. It's
That
not
is
that.
why I intentionally targeted you.
Yes.
Sorry,
Yes.
because teacher knows who don't know.
Yes, sir. You got me.
Sorry. Yes, Dr. Sami. Once again, you are on the front foot. Dr. Sami. Yes. You there in the class? Yes. Okay, so probably she is hungry, don't want to answer. Dr. Abram. Dr. Abram.
Yes, sir. I choose the D option, but I think it's wrong. So I have no idea now.
No problem. I'll give you the. I'm a very good person. Dr. Munjal is good person, so I'll give you the liberty. Choose another answer.
Okay.
If you don't want to go for B, in exam you have no options. I'll give you now. If you don't want to go for B, 1 minute. Let the Abram finish. So we discuss. I'm not in hurry. So you think over it for answer, Dr. Abram. I'll respect your opinion. Meanwhile, I'll go to Suresh Kumar. Yes. Yes, Dr. Sir. Suresh Sir. If you are in the class. Yes, some lady was speaking. Sorry, tell me. Guru Kumar is brilliant man. He has noted down everything. Wonderful.
In this, hello.
Yeah, what's your name, doctor? Sorry.
Sir, Dr. Monica.
Dr. Monica. Yes, tell me.
Sir, I want to say fictitious complaint is characteristic symptom of Munchausen syndrome.
Okay.
So the answer, when we think of C as the answer, Munchausen syndrome.
So what is exactly this Munchausen syndrome is what?
Munchausen syndrome is fictitious complaint and the patient keep coming on to the doctor seeking his attention, seen mostly by the parents who are drug abusers. They take their children for seeking with a fictitious complaint.
But here they are saying that an old man comes to the doctor complaining part of his body is rotten and
But
he wants to cut it, remove it,
a
part of the
fictitious
body.
complaint. It is
Okay.
a fictitious.
So homework for everyone to understand what is guilt, what is hypochondriasis, what is Munchausen syndrome, what is nihilism, and what is Capgras syndrome. One question 200% will come in exam. So don't ignore, read it, think it, we'll discuss again. Nihilism, listen, nihilism, part of the body do not exist or are dead, right? This is what they are thinking, right? Guilt is an emotion. This is classical fix. Part of the body do not exist or dead. This is what the fix. This is a specific word. This is nihilism. Guilt is an emotion that occurs when the person feels that they have violated a moral standard. Guilt. You feel guilt feeling, right? Oh my God, I didn't did good for this person, right? We feel a guilt, right? In spite of I am behaving good to you, you are not behaving good to me. You probably later on you feel guilt. Oh, I did not behave well with the sir. So it's fine. This is a feeling. It's a feeling. It's a personal feel. It's a personal feeling or feel. That hypochondriasis, very clear cut message. Worry about having a serious illness, which is not there. The word is missing here, which is not there. So say for example, one patient. This is classical. Your exam, this exactly copy paste question. 50 years male presented with you, blah, 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 blah. He's thinking that he has HIV. He goes to the multiple doctors. Multiple doctor did HIV. All doctors, all everything is negative. What is the diagnosis? Hypochondriasis. In spite of having no disease, patient feels that I have a disease. Is that clear? Same the cancer. Patient has abdominal pain. Patient has epigastric pain. Patient thinks I have pancreatic cancer, right? He did all scan, he did all MRI, he did multiple time endoscopy, he did all whatever the possible test available in world, he did it all negative. Still patient think that I have pancreatic cancer. It's a hypochondriasis. Is that clear? Is that clear? Yes or
Yes, sir.
no? So
Yes, sir.
hypochondriasis is one line definition. Worry about having a serious illness which is not present. Example is HIV, example is cancer, example is so repeatedly. So question in your exam either DHA or the MOH, the same way come the some patient feeling I have some gastric tumor. He did 50 times endoscopy. He did multiple endoscopy in last 1 year. Everything is normal. Hypochondriasis. That's it. Munchausen's psychiatric factitious disorder, wherein those affected feign disease, illness, or psychological trauma to draw the attention, sympathy, or reassurance to themselves. Right? This is Munchausen. Nihilism, body part does not exist or dead. Specific nihilism. Right here, the broad spectrum. Right? Disease, illness, or some psychological trauma. They create. Why they create? Because they wants to draw the attention, they wants to draw they wants to get a sympathy, or right, they want to reassurance to themselves. Oh, today's days is very bad. My mood is not good. I don't want to go to the hospital. Right? Right? You are very tired. Then your parents pampering you. Oh, beta, don't go to the hospital. You did a lot of hard work. Right? So you are trying to get a sympathy. You are trying to get attention. Our kid don't want to go to school. Oldest example, our kid don't want to go to school. At that before the time of school, you say, Mom, Dad, I have a lot of pain in tummy. Now you are getting simple. Oh, he has a pain in tummy and don't go school, beta. And after saying that, he is now enjoying like anything. He is playing cartoon game for whole day. Now there is no pain. Is that clear? And Capgras syndrome, delusion. Again, homework. What is delusion? What is illusion? What is hallucination? Lots of doctors have confusion in their mind, right? How to differentiate delusion, illusion, and hallucination. Go and read it. A delusion means fixed and false belief. That is delusion. Illusion means a visual, means magician, jadugar, magician. He's do magic in front of you. What he's doing? He's doing a visual illusion. Visual illusion. He's making, he is playing the cards, and then all of the sudden pigeon is coming out of the card. What is it? It is a visual illusion. Delusion is what? False, fixed belief. False but fixed belief. False but fixed belief. That opposite neighbor, female, wants to marry me. She don't want to marry you. False but fixed belief. Right? Got it? Yes or no? So this is a delusion. False but fixed belief that a friend, a spouse, a parent, or other close family member has been replaced by identical looking impostor. That's it. So this is Capgras syndrome. So go and read it little bit. Though psychiatry is not a major chunk of the MCQs in exam, but they do ask. Couple of students I was talking few days back, they were saying, sir, I have a lot of questions from psychiatry. So I don't want you to ignore any subject. Your core subjects for your knowledge, once again, repetition, surgery, means general surgery, gynec, pedia, emergency medicine, legal ethics, and rest other things. But you cannot ignore, unfortunately, no fixed syllabus in DHA, HAD, or MOH that, okay, geriatric medicine this weightage, cardiology this weightage. And if my humble request, if anybody gets this breakup, please do let me know. Please do let me know. Please share in the group. So far, by my knowledge, they can ask you 50 questions of gynec, they can ask you 50 questions of psychiatric. It's all depend on their mood. That's it. But in general, my 10 years of experience coaching with a PROMETRIC, 5, 6 are the major subjects, but you cannot avoid any subjects. So these are all definitions, blah, blah. So it's a long list. So you can read it later on. 5 of 5 is excellent score. We are half the way of the class. With your kind permission, I'll just get a glass of water. My throat is very bad since yesterday, but I don't want to skip the coaching.
Yes, sir.
Wonderful. Meanwhile, you have good time to interpret this question and get back to me. So utilize your 1 minute interpreting the question answer. Very excellent and commonly asked question. I'll get back to you in 60 seconds. Yes, are you ready? Am I audible? Yes, no?
Yes, sir, you're right.
Yes, sir.
Wonderful, wonderful. So probably I don't need to read the questions. If yes, tell me, I'll read. Probably the easier questions, but there are very less answers, so I'm not happy. Yes. Yes, any volunteer, any volunteer. What's the answer and why is the answer? Anyone. I wish that who never interacted with me just interact once. Dr. Uttara, are you there in the class? Yes or no? Dr. Laru, would you like to comment?
Yes,
Doctor,
sir, I am.
you are there, Dr. Uttara? Yes.
Yeah,
So,
I am here.
yes, yes, very nice. Welcome. So what's your thought process on this question? So you are sitting in your OPD in your clinic, right? And 66 years old man, right, coming for the follow-up in your office. He was placed on the metformin for type 2 diabetes after not responding to modification of diet and exercise, means lifestyle modification did not help him despite the maximum dose of metformin. So lifestyle changes, no response, started metformin, no response, escalate up to the maximum dose of metformin. So first of all, tell me, Dr. Uttara, what is the maximum dose of metformin?
1000
No.
BD.
2000.
2000. Any more questions? 1000, 2000, 2500, 3 gram.
1000 BD.
1000 BD basically. So 2000 in general. I mean, total dose means maximum dose means in 24 hours. It implies 24 hours. Maximum dose in 24 hours is 2 gram. Anyone else? Any other questions? Exam question. Huh? We discuss this question for 15 minutes. All diabetes will cover. Anyone?
Okay.
Yaswini, if you are in the class.
Sir, I guess it is 2 grams.
2 gram. You guess 2 grams. So you go and open up the book. Dr. Prezi, any comment? Dr. Prezi, any comment from your side? If you are treating the patients in OPD, you must know. Dr. Sami, any comment? So your homework is to find out what is the maximum dose of the metformin, number one. Second questions, which vitamin deficiency can caused by metformin in long use? No option. Which vitamin deficiency can caused by
B12.
metformin? Sorry?
B12.
Excellent, brilliant, brilliant. B12. Because when you give the metformin, right, the commonest side effect is a GI side effect. And in a chronic use, it causes the B12 deficiency. So any patients on metformin develop anemia, especially megaloblastic anemia. Think that this patient is developing now B12, or when patient is developing peripheral neuropathy. Probably it could be because of diabetes, it could be because of B12 deficiency or folate. So this is second question. Third questions, how the metformin works, what is the mechanism of action? These all are the hard questions DHA and MOH, believe me, don't take it lightly. What is the exact mechanism of action of metformin? Anyone, open for all. We are 35 people in house.
It increases the bioavailability of insulin that is already
It
produced in the body.
increases the bioavailability. What do you mean by bioavailability?
The amount of actual insulin that can act on the body, the diet,
Okay,
or
fine.
which can be used by the body.
So if I can make it in a simpler word, it increases the sensitivity to the end organ.
Yes. Yeah.
Okay. Okay. So when you give the oral pill, are you Catherine?
Sorry?
Are you Catherine?
No, I'm Uttara.
Sorry?
Uttara.
Uttara. Oh, sorry. So great. So when you give the oral metformin, right, it goes to the esophagus and then stomach, it gets absorbed, right? And then where it acts, what exactly it does in the body to reduce the sugar? It improves the insulin sensitivity. Then
yes.
Second thing is, before that,
It inhibits the glucose which is made in the liver.
okay, so it is not act on the insulin, it acts on the glucose in the liver, means glycogen. Metformin does act on the liver, insulin directly on the pancreas or not? So when you give the oral metformin, you had given to the patient, does it secrete the insulin? Yes or no? Yes or no?
No.
No, it does not have any effect on insulin. It reduce 3-4 action. Simply remember, read it. This is absolutely will ask in the exam. You will remember me in the exam room, believe me, because all this you see in front of your screen, black and white, right? So don't ignore it. Go and read the mechanism of action of metformin. But still, I'll tell you quickly. It reduces the glucose absorption, number one. Number two, it improves the sensitivity of the insulin towards the end organ. Right? And it increases the process of gluconeogenesis. Right? So what happens basically when you eat the food, glucose level will rise. Right? When glucose rise, insulin released from the pancreas, tails of the pancreas. Name is a beta cell. Langerhans. Go and read the physiology. Langerhans, tail of the pancreas, beta cell. Beta cell increases, release the insulin. Alpha cell releases the glycogen. Glycogen and insulin. Glycogen, insulin reduce the glucose, glycogen increase the glucose. So balance mechanism, right? So this metformin will increase this things, right? It has nothing to do with the pancreas. It has nothing to do with the insulin release or insulin things. And that is why the hypoglycemia is the least in metformin, because it is not at all dealing with the insulin. So the biggest advantage of metformin is, even in a higher dose, 2 gram, 3 gram, it does not cause the hypoglycemia, right? It does not cause the hypoglycemia. Biggest advantage of metformin. It is the first line treatment. If they ask you what is the first line treatment of, means in terms of drug, what is the first line pharmacological agent for the things, right, for anti-diabetic, it is none other than metformin. Across the globe, thousands of literature, metformin is a drug of choice. What are the contraindication of metformin? Exam questions. Lactic acidosis is the worst side effect of metformin. Commonest side effect is a GI intolerance. These all are exam questions. I'm telling you very quickly, right? So this is the things, right? So there are lots of advantage of metformin. It does not cause hypoglycemia, biggest advantage. It also cause the weight reductions of the patient. So obesity, it also again helps in obese patient. If you start metformin, it just not control the glucose, it controls the weight as well, right? It reduces the cerebrovascular, cardiovascular, and peripheral complications compared with other oral hypoglycemic agent. I am giving you the brief summary from the book, what I remember. It's not written here, but just keep in mind. right? So it increases the all-time mortality compared with any other OHA, that is oral hypoglycemic agents. So metformin is the drug of choice. Can anyone tell me what is absolute contraindication of metformin, that you cannot use metformin? It's a first line drug. So whenever any diabetic new patient comes, I'll tell them, okay, yo, gentlemen, you go and do the diet, exercise, blah, blah, lifestyle modification, 3-6 months. If does not control, come back to me, I will start metformin. But after evaluating, I say, oh, you cannot take metformin. What's the absolute contraindication? Not relative. Relative is little you use, you cannot use. Absolute means 100% you cannot use.
Renal
Anyone?
impairment.
EGFR is less than 30.
Excellent, 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 excellent. So renal impairment, EGFR, especially less than 30, or bad renal failure, it is try to avoid the renal drug. I mean renal failure patient, it does the lactic acidosis. So just only thing for you stopping prescribing metformin is a renal insufficiency. Dr. Yashwini, are you getting me?
Yes, sir.
So after this, right? So now come to the questions. We discuss a lot of questions. So you need to know what is the maximum dose, what is the mechanism of action, vitamin B deficiency, how the metformin works, what are the advantage and disadvantage of metformin, contraindication of metformin. Now, metformin given in the maximum dose, still the blood glucose is 150/90. HbA1c means glycosylated hemoglobin. Have you heard of this word? Glycosylated hemoglobin is above 7%. Normally, it's supposed to be less than 6.5. Exam question. What is the range of non-diabetic patient in HbA1c? Anything more than 6.5 is a diabetic. So HbA1c is above 7%. What is the best next step in the management? So add a glyburide, add insulin subcutaneously, add insulin pump, add rosiglitazone, add acarbose or miglitol, or add or switch. Switch means what? Switch means you stop the metformin and switch to the sulfonylurea. That is the meant for add sulfonylurea is different and switch sulfonylurea is different. So here they are not saying stop, I mean add, they are saying switch to sulfonylurea. So what's your answer? Very interesting. Yes. Yes, anyone? Open for all. Anyone? Any volunteer? Yes, Dr. Uttara, any answer? Dr. Uttara, Dr. Presi, I did not heard from you, so sorry to ask you. Dr. Roshan, Dr. Sharvi Oberoi, any comment?
Switch to sulfonylurea.
Who is this?
Change the switch. I'm Uttara.
Yes, switch to sulfonylurea. So why you want to switch to the sulfonylurea? So you stop now. Patient was on maximum dose of metformin, right? So now you want
Yeah,
to
he
stop the
wasn't.
metformin and you want to start the sulfonylurea.
Yeah.
Why you don't want to add a glyburide? Sorry.
No, he wasn't responding to metformin. So
Okay,
let's switch.
fine. So whenever the metformin is not responding, you stop the metformin. How you treat in your OPD? No problem. I'm happy. At least you are answering. This is a absolutely excellent learning platform, I guess. So, so add glyburide. Add glyburide. Before switching to the glyburide, let me give you what is a glyburide, right? Otherwise, you get confused. So I got excellent chart here for your better understanding. Insulin secretogenous. Insulin means they directly act on the insulin, and that is why sulfonylurea, the worst, the biggest side effect is hypoglycemia, which is not there in metformin, because in metformin does not act on insulin. Sulfonylurea directly act on pancreas beta cell, tail of beta cells, and tell the beta cell to release the insulin. So it is an insulin secretogenous, right? So it stimulate the insulin to secrete directly. And when the insulin release, if you don't eat the food, they get hypoglycemia, patient get sometimes hypoglycemic coma, right? So they must have to be very vigilant on the sulfonylurea. These are the drug, tolbutamide, chloropropamide. These are the two old drug with little side effects, so not much in the market for your knowledge. Glyburide, glipizide, glimepiride, and glabenclamide. Another drug is glabenclamide. So this all G, glyburide, glipizide, glimepiride, and glabenclamide, right? These are the drug which directly acts on the insulin, right? So it quickly reduces the sugar, but same time quickly do the hypoglycemia. So whenever the metformin does not work, you don't need to stop the metformin. You add one more drug, that is sulfonylurea. If metformin maximum dose, sulfonylurea maximum dose does not work, then add DPP4 inhibitor like vildagliptin, sitagliptin, hexagliptin. So I shortly called as a gliptin family. Is that clear? Again, if not act with this SGLTD inhibitor, and if it is not responding, then you don't have any much option. Now you start insulin. So before starting the insulin to any diabetic patient, you have fairly a good amount of the drug which reduces the glucose. So insulin nowadays, especially for type 2 diabetes, it's not an initial option until and unless patient directly present with diabetic ketoacidosis in emergency. So obviously this is emergency. So what fastest reduce the sugar is insulin. So in DKA patient, if comes, you use insulin, otherwise walking, talking, moving around 8, 9, 10 HbA1c, right? At least less than 10
What
HbA1c.
do we add Voglibose?
Voglibose.
Yes, sir.
Voglibose is a carbose, right? The
Yes, sir.
drug Voglibose, acarbose. This acarbose, this miglitol, acarbose or Voglibose, right? Bose is Voglibose. So what is this Voglibose basically? So if you can see here, Voglibose is a drug, right? Voglibose is a drug, alpha glucosidase inhibitor. So what happened? What happened? I'll tell you. When you eat the food, right, it increases the level of insulin in the body, sorry, glucose in the body. Insulin get released.
Yes, sir.
This alpha glucosidase inhibitor, or this is enzyme alpha glucosidase, just google it, alpha glucosidase. What is it? It is a basically a enzyme. It is situated in the mucosa of the intestine, right? And it helps to absorb the glucose. It helps to absorb the glucose. So what happens if you don't want to increase the glucose? You block this enzyme, right? So alpha glucosidase inhibitor means it blocks this enzyme. So if you block this enzyme, glucose will not get into the intestine to circulation, then glucose will not increase. It is especially used for the patient who has a postprandial blood sugar very high. Postprandial.
Okay.
After meal, too much of high in the blood glucose. Obviously, na? Before
Got it.
fasting is less. Postprandial high. Why? Because you had eaten, right? So those
Yes.
patients, say for example, one patient comes to you with fasting blood sugar is 100, reasonable, normal, close to normal, but postprandial is 250. You want to reduce postprandial. How you reduce? Add the alpha glucosidase inhibitor, Voglibose, acarbose, miglitol. Is that clear?
Got it, sir.
Any confusion?
No, sir.
Wonderful. So this is the drug. So you just go through it. I mean, I don't want you to do PhD in anti-diabetic drug, but three things you must know. One is metformin. The group is biguanide. Have you heard of this group, biguanide? Yes or no?
Yes, sir.
Biguanide is a metformin, right? Sulfonylurea is this drug which secretes the insulin. Biguanide is a metformin, right? And acarbose, insulin, thiazolidinediones. This is again a group of drug, again anti-diabetic. Rosiglitazone, hexaglitazone, pioglitazone. These are the few drugs, but you should not miss out the three things. One, you must know sulfonylurea. You must know biguanide. Third thing, you must know the insulin. That's it. That's it. Basic things you must know, not very much in detail, but how they acts, how they works, what are the basic side effect, and when to add what drug. I given you the general idea how and when to drug. So once gets failed, this is international guideline. I got it from the internet. Diagnosis of type 2 diabetes. All patients advised lifestyle modification in the first upper block. FPG, fasting plasma glucose, HbA1c, and diagnosis and follow-up. So whenever this is how the triage comes, this is how. So whenever you have any patients in your OPD, right? So what you do? Okay, you check the blood glucose. You confirm that this is diabetes mellitus type 2. Now, what's the first step is to check the HbA1c. If HbA1c is 6.5, lifestyle changes is 6.5 to 8, lifestyle changes plus metformin, oral anti-diabetic. OAD is oral anti. First is metformin. You cannot miss metformin until and unless there is a very bad kidneys to the patient or renal failure. In that case, you directly jump on the sulfonylurea. This is question. If the patient has a bad kidney, patient is on dialysis already, and patient detected to have diabetes, what is the first line treatment? Sulfonylurea. But when the kidneys are normal, first line is metformin. In any patient, metformin, first line treatment. If the kidneys are bad, then first line is sulfonylurea. If kidneys are good, sulfonylurea plus sulfonamide. If it is maximum dose, not responding, DPP4 inhibitor, not responding, right? Gliptin family, right? That's it, insulin. So this is what the chart mean to say. So first you add 8 to 10, still you try the combination of therapy with metformin, with sulfonylurea, with or without insulin, and this is the only chain where the HbA1c is more than 10, then your first therapy is the insulin. It is too high, too high. You cannot control it very fast with the oral hypoglycemic. So anything more than 10 at the time of diagnosis, HbA1c, better to place them on insulin for few weeks. Once they get settled, once the HbA1c get down from the 10 to 8, 7, 6, then you switch to the oral again. Again start with the oral with 6 HbA1c or 7 HbA1c, metformin, add sulfonyl, add another, that's it. Right? So this is how generally it is been treated in clinical practice. So these are the all these various things. I'm not going much in detail. I already told you. So I'll forward the PowerPoint. Bear with me. Last couple of questions. 6 out of 6 is a brilliant score. Brilliant. 6 out of 3, so less than 3, not good, bad. Need to prepare more yourself, right? And get our help for coaching. 70-year man with a history of hypertension, diabetes comes to the emergency department with a sudden onset of weakness in the right arm and leg over the last hour. On examination, he cannot lift the bottom half of the right side of the face. What is the best initial step? Are you going to do a head CT with contrast? Are you going to do head CT without contrast, aspirin, thrombolytic, MRI brain? Your time starts now. Though it's a
Head
easy
CT without
questions,
contrast.
so let's other people to think over it. Probably it's easy, but still we sometimes make a silly mistake in easy as well. Yes, Toprak, you did a mistake. I want to understand why you want to give thrombolytic. Explain me. So explain me what is the diagnosis first of all, Toprak.
Because
So what's the diagnosis? Don't worry about right or wrong. You will never forget after discussing with me. So what's the diagnosis? Read the scenario again.
diagnosis is DVT.
Sorry?
DVT.
DVT. Okay, DVT. So where is the DVT? In which vein you feel there is a thrombosis? DVT is, I understood, deep vein thrombosis. So in deep vein, which deep vein has a thrombosis? Read the scenario.
Actually, he's already elder person and has hypertension. Is hypertension and diabetic weakness his vein.
So do you feel, just sorry to bother you in between, do you feel in a DVT there is a weakness in right arm, only right arm, not in the left arm? Do you think in
and
DVT,
leg.
do you think in the DVT there is a facial asymmetry or facial drooping or facial weakness in DVT?
Actually, no.
Okay. Would you like to change your diagnosis?
Um, sure, but I don't know
No
what.
problem. Think over it.
which one.
Think over it. I'll get back to you. Think over it. No problem. It's a learning platform. Yes, Dr. Sami.
Maybe trace falsy.
Yes, Sami.
Yes, sir.
CVA.
What's your diagnosis?
It's a stroke.
It's a stroke. Okay, it's a stroke. So what point favors the stroke in this patient?
So see, a sudden like weakness of the arm and the right side of the face.
Excellent. Wonderful. So this is a stroke, right? Some kind of this vascular insufficiency, probably in the
Yes.
brain, isn't it? Right? So what are the risk factors? Stroke doesn't happen in a normal person. Usually 70 years is the risk factor.
So hypertension.
Hypertension is the biggest risk factor. Diabetes, again a super duper risk factor. And along with the high risk, patient develops sudden, it is not chronic, sudden onset of weakness of the arm and weakness of the face in general, right? Arm and face. So what comes first in our mind is a stroke slash TIA. I mean, in general, right? TIA, transient ischemic attack or stroke. I'll ask you later on difference. So it's basically TIA slash stroke. So now this patient, you are suspecting this patient as this has a stroke, either hypertensive mainly, right? So what could be the investigation of choice? So your diagnosis clinically stroke. Now you want to do the investigation. So what is the best among these things? Initial step is what?
Without contrast.
How?
Without
So how
contrast.
many believes that contrast make your video on and tell me, raise your hand. Contrast how many? No one contrast. No contrast.
No contrast.
Why?
No contrast.
Without contrast, how do you get to know?
Because
Sorry?
I mean, initially we do not know if his kidney, urea, creatinine, if they're good.
Okay.
So without contrast, we can make a diagnosis.
Excellent. Wonderful. So contrast is not needed usually when there is a when you have a stroke. Contrast is not needed, right? You don't need contrast to specify the clot, blood clot, right? So first and foremost investigation for any stroke patient or suspected stroke. So let it go it in that way. Suspected stroke. First clue is the clinical features, right? Clinical features, and this is clinical feature excellently narrated here by my terms. It is a be fast. Whenever you see be fast, think of stroke. Be fast. What is be fast? Change in the balance, change in the eye movement, facial asymmetry or facial weakness or facial drooping, arm drift or unable to raise the arm, difficulty in speech or slurred speech or all of sudden changes, and time is the extremely important for the management. First 3 hours we will discuss that. So time is extremely important. So be fast whenever any patient comes that I have all of sudden change in the balance, change in the eye movement or sudden loss of vision is a stroke because of the carotid or retinal artery gets blocked because of stroke, because of atherosclerosis, and blood is not flowing to the eye, sudden blindness. Blood is not flowing to the facial artery, facial asymmetry, right? Blood is not flowing to the cortex, upper limb weakness, right? Also same way, lingual artery and all blah blah. So be fast. So these are the symptoms. These are the symptoms of be fast. So whenever I get a call in emergency, though I'm not getting call, I'm hematologist, but whenever my patients sometimes say, sir, this has a weakness, blah blah. So I think of quickly of some stroke and I go and get it the CT scan of brain plane done. Why brain plane? What is the things plane? Why I'm insisting on the plane? So prior to administrating Toprak, prior to administrating the thrombolytic or any anticoagulant, you need to rule out hemorrhagic stroke, Toprak. Are you agreed? Right? So
yes, I understand.
Right. So what happens? Say for example, this is the brain, right? On CT scan, you have major bleeding here, you have a big clot here, right, in cortex frontal, this is occipital, this is frontal. So you have big hemorrhage here, and on top of that you are give thrombolytic. This patient will die immediately. There is already bleeding, and you are trying to make the blood more thin by giving the thrombolytic. So thrombolytic, right, in hemorrhagic stroke is absolutely contraindicated, and without doing the CT scan, no person in this world can tell from the history whether this is hemorrhagic stroke or ischemic stroke. Only and only CT scan without contrast is the fastest test. If the CT scan of contrast cannot give you the clear idea, then next investigation of choice is MRI. If MRI cannot give the idea, then you do MRI angiogram. These are the investigation of choice chronologically. So first, don't skip the basic investigation, that is CT scan. CT scan, if inconclusive, then go for MRI. If inconclusive, go MRA, MR angio brain vessel. This is how we do in clinical practice. So don't give the thrombolytic without doing the imaging. So what imaging? CT scan, right? You cannot give aspirin. Aspirin, again, it's a brother of thrombolytic. It increases the bleeding. So without thrombotic or ischemic, hemorrhagic or ischemic stroke, don't give the aspirin as well, don't give the thrombolytic as well. So first do the CT scan. CT scan non-contrast. Why? Remember, 20% of the stroke are hemorrhagic, means 80% are ischemic. You do not need contrast to visualize the blood. You don't need contrast to visualize the blood. If it is obvious, even without contrast, you can see, oh, this is very big clot in the brain. Radiologist, I mean, it's not none of your job, my job. I'm a clinician, you are a clinician. But the trained radiologist or neuroradiologist can easily tell, okay, sir, this is a hemorrhage. So don't give thrombolytic, don't give aspirin, don't give clopidogrel, don't give any this platelet drug. That's it. It's a hemorrhagic stroke. So once you confirm that this is a ischemic stroke, then you give the drug treatment. Can anyone tell me what is the treatment of ischemic stroke? Exam questions, frequently asked questions, recall question. Go and read it. Go and read it.
Thrombolytics.
Go and read it. You are right.
Aspirin.
So there is a time
Also
frame.
statin.
There is a time frame, doctor. Time frame. When the patient
Yeah.
presents to you, right? So you have a stroke, right? You did the CT scan. You confirm ischemic stroke. Is that clear? Then first questions comes to your mind, at what time present at the time of the symptoms to you for the treatment. So what happens? 12 o'clock patient presents to patient has a symptoms at 11 o'clock in the morning. 12 o'clock it reached to the hospital. 12:30 CT scan was done. 12:45 or 1 o'clock we get to know that it is a ischemic stroke. So 11 to 12 and 12 to 1. So within 2 hours, everything is done. Up to the CT scan diagnosis is done. This is ischemic stroke. So within 3 hours, it is called as the golden hours for stroke people. 3 hours thrombolytic. 3.3 to 4.5 hours possible role of thrombolytic. Possible role of thrombolytic plus aspirin mandatory, absolutely ischemic stroke. And more than 4.5 hours, no role of thrombolytic. Just give aspirin, max clopidogrel plus anti-lipid like statin. You know statin, atorvastatin,
Yes.
rosuvastatin, right? Simvastatin. So cystatin is an anti-lipid agent, anti-cholesterol, right? This you can give, right? So again, you need to know what time frame. If they ask you in the exam, patient present within 3 hours, answer is thrombolytic. If the patient present after 6 hours, answer is aspirin. That's it. So this is basic. So you get to know more in detail. I given you the perfect answer in short summary, but stroke is the leading cause of morbidity and mortality across the globe. So go and read it very well. So that's all. I'm concluding these things. 7 out of 7 is the best. I'm finishing my talk very soon. Just bear with me for more 10 minutes. 20-year male with blood in the urine on several occasions since past year. Each episode associated with respiratory or flu-like symptoms. Urine dipstick shows mild proteinuria and microhematuria. burn normals, blood urea nitrogen normal, serum IgA elevated, diagnosis, Berger, good pasture, minimal chain disease, post-infectious glomerulonephritis, and Wagner granulonephritis. Glomerulonephritis. Sorry, so automatically I pushed my button. Sorry. So this is IgA nephropathy. The most important clue in this is IgA level is high, IgA elevated. So whenever IgA elevated, it is called Berger disease. Berger. The another name of Berger is a IgA nephropathy. Both are the same thing, like noradrenaline and norepinephrine. And noradrenaline and norepinephrine, same thing. Berger and IgA nephropathy is the same thing, just for your clarity, right? Can Dr. Yashwani, you can tell me what is a good pasture syndrome? What is a good pasture syndrome? Yash?
Sir, I don't recollect.
No problem. So your homework, all I will ask you in the evening, don't sleep, eat and
Yes,
sleep
sir.
today, right? All will come in your NEET PG exam as well. So good
Yes,
pasture
sir.
syndrome. Anyone open for Dr. Prezi, Dr. Saima, Dr. Roshan, Dr. Sami, Dr. Sharvi,
So
anyone?
it's a condition.
Yes, and good
So it's a
pasture is
condition. It's a condition which affects the lungs and the kidneys, where the antibodies are produced against the lungs and the
wonderful,
kidneys.
wonderful. So your concepts are clear, right? So Berger is a basically kidney and good pasture is kidney and the lung. So IgA nephropathy, also known as a Berger disease or synpharyngitis glomerulonephritis, is a disease of kidney or nephropathy and the immune system. Specifically, it is a form of glomerulonephritis or an inflammation of the glomeruli of the kidney. Aggressive Berger disease can attack other major organs like liver, skin, and heart. IgA nephropathy Berger is a most common cause of acute glomerulonephritis in the United States as well as in India. You see many patients. Look for an Asian patient with a recurrent episode of gross hematuria. So how do they give you the history? Blah, blah, blah. Patient presented with a gross hematuria followed by the upper respiratory viral infection. What is the diagnosis? IgA nephropathy, right? And 1 to 2 days after history of upper respiratory tract infection, the patient, this actually helps because of IgA disease is most common cause of glomerulonephritis, and IgA means immunoglobulin A will rise in the plasma. Treatment of Berger. There is no treatment, proven treatment of Berger to reverse the disease. So what you can do then? 30% will completely resolve by their own, 40 to 50 will slow the progress to a end stage renal disease. So sometimes you can I mean 30%, 40% will resolve by their own immune system, but 40-50% will eventually develop from IgA nephropathy to the end stage renal disease and eventually on the dialysis and renal transplant. Severe proteinuria, if protein is going very badly in the urine, patient has hypoproteinemia, patient has hypoalbumin in the plasma, patient has a lot of edema, a lot of ascites, pleural effusion, so proteinuria manifestation. So severe proteinuria is treated with ACE inhibitor and steroid. That's all. So this is all IgA nephropathy. Last but not the least, 8 of 8 is excellent score, 8 of out of 4. Not bad, less than 4, extremely bad. 25-year-old man presented with, so everyone's homework, sorry to give you the homework, but you need to do what is Berger, what is good pasture, and what is Wagner. That's it. So Wagner also you need to know. Considering the time, I am little skipping couple of more questions to just catch up with my timetable. So Berger's disease, good pastures, and Wagner's. Three things you must know. 100% questions will come from this. 25-year-old man presented with a painless 3 centimeter testicular mass that discovered while taking a shower. While he was bathing, shower, taking, he found that young man who has a testicular mass. Physical examination confirmed the mass arises from the testicle itself, not a part of epididymis, and is a solid rather than fluid collection. The rest of physical examination is unremarkable, means normal. Which of the following would be most appropriate next step? Are you going to do serum AFP beta HCG transscrotal biopsy of the mass, transscrotal incisional biopsy of edge of the mass? You do transscrotal orchiectomy, you completely remove the orchiectomy, and you do radical inguinal orchiectomy. Surgical questions. This is surgery question. Testicular mass is a surgical question. Quick. We are a lot of people still in the house. Yes, Yashwani. What do
Yes,
you
sir.
do? What do you do, doctor?
Sir, I'm just reading the question.
Question is a simple. I'll give you the summary. 25-year young man, while he is taking the shower, he found to have there is a one testis is bigger than another, 3 centimeter hard mass felt on the palpation. Now he comes to you. What will you do? That's it. This is the question. You operate, you do blood test, you do CT scan, MRI, or you remove the testicle. Yes, so answer is A. That's correct. So Toprak, what do you think? What could be the diagnosis?
It is testicular cancer.
Great. So this is likely a testicular cancer, right? Because
Yeah,
it
it's
is usually in the young age, right? It is a hard mass, it is a firm mass, right? So you should
yeah,
not miss the
and
test. And they have clear cut mentioned that there is a no growth from epididymis and it is not a fluid, it is a solid mass. So it's a highly suspicious of malignant mass, isn't it?
yes,
Great.
and penis lump in the scrotum. It is suspected for testicular cancer.
Okay.
And alpha fetoprotein and HCG is elevated in all of them.
Okay.
And is important seminoma or non-seminoma.
Great, wonderful. So that's the second step, right? But first of all, you will going to do, right? So you have a painful scrotal mass or testicular mass. You first do the testicular ultrasound. Ultrasound will give you only two idea whether it is cystic or solid. You will not get any information more than this in ultrasound. So it is solid. It is already mentioned. Now you do the AFP, beta HCG, and third hormone write down as well, LDH. Three things. Can Toprak you tell me AFP is increase in what other malignancy? Say for example, AFP increase in a testicular cancer. What other condition where AFP is increased? Another cancer? Anyone open? Yeah, Toprak, you can think and tell me. Meanwhile, other can also answer.
Choriocarcinoma, alpha fetoprotein level is increased.
Choriocarcinoma. Then other, if I add as a hemato-oncologist, HCC, hepatocellular carcinoma, alpha fetoprotein is increased if I'm not wrong. Yes or no?
Yes. Yes.
Wonderful. So these are the few conditions. So you do, once you do these things, right? So once you have a testicular mass, you do the USG and AFP, USG is favoring, HCG, AFP, LDH is favoring. Then what next? What's the treatment you do for this patient? You found, you confirm. So are you going to do a biopsy or you directly go for the surgery? Topra.
Biopsy.
Sorry? Anyone?
First step, biopsy, I think.
So this is the only exception. Never ever do biopsy in testicular cancers. This is exception. Never ever do biopsy. When you do the biopsy, either true cut or transscrotal, extremely high chance of metastasis or spreading the tumor or shedding the tumor cells. So don't do it. Directly go for high inguinal orchiectomy. That's it. This is the word, high inguinal orchiectomy. So your homework, surgery questions are a lot of asking in exam, especially testicular tumor. It's a highly curable cancer amongst the male, right? So you go and read it. So first confirm diagnosis by the clinical presentation, history, ultrasound, and tumor markers like AFP, beta, HCG, LDH. Once it's all favoring the cancer, directly go for orchiectomy, no biopsy. That's it. Last but not the least, will catch up. 55-year woman with weak limbs on examination, neurology questions. So I included all varieties of questions. This is neuro question. 55-year woman with a weak limb on examination found to have burn mark on fingertips, right? And wasted and weak hands with diminished reflexes. She also has weak spastic legs and dissociated sensory loss. What is the most likely diagnosis? Multiple sclerosis, GBS, Guillain-Barré syndrome, motor neuron disease, syringomyelia, none of the above. Last question. Probably toxic. Probably you don't like me today. Yes, Nandini. Any comment, Nandini? Nishant, Prezi, Roshan, Sharvis, Sumera, Gul. Any comment? Any comment? Sarin, Dr. Naresh Kumar, Laru HL, Dr. Exita, iPhone. Any comment? No comment. Is it a tough question? Yes, Prezi. I'll come to you, sir. Yes, Prezi. Describe this. How you describe this? Yes, Sharvi. Why it is a motor neuron disease? What things it makes you the motor neuron disease? Dr. Sharvi? Anyone? Motor neuron disease, anyone? Speak up point favoring the motor neuron disease. Because you must have seen something, right, that this favors motor neuron. So why there is a sensory, right? In motor neuron disease, there is a weak limb, or why there is a burn marks on the fingertips, or why there is a diminished reflexes. Do you think this is all seen, and there is a dissociated sensory loss in motor neuron disease? Yes, tell me. Anyone? Open. Sorry. So first of all, for this homework is this all 5 conditions little. Yes. Tell me, doctor.
For me, out of the option, multiple sclerosis, they didn't mention about like, the diagnosis or confirmation with the head CT or something like that. Then GBS, it affects the respiratory system also. I mean,
Okay.
But-
So GBS is not there, right? By you?
No.
Okay.
No.
Multiple sclerosis is not by you.
No.
Why no? What happens in
Because
multiple sclerosis?
it affects the eyes, every part of the body. No?
No, but
Sclerosis.
where is the sclerosis is where? Which part of the body there is a sclerosis? It's a
In the
multiple place
brain.
now. In the brain. Specifically more in the brain.
Yes.
Huh? There is a problem in the insulation. Have you heard of sheath, nerve sheath, neuronal sheath,
Yes.
axon, dentricles? Have you heard of it?
Demyelination, yes.
Right. So it's a demyelinating disease. Insulation, conduction is affected in multiple sclerosis. Right. So mainly the optic nerve is involved very commonly. Patient may present with a blindness which is not there. Right.
Yes.
Guillain-Barré is a ascending this neuropathy. Right.
Yes. Limbs are-
Poliomyelitis is descending, going from head to toe, while GBS going toe to head, ascending.
Yes.
Right. So first lower limb,
Yes.
and then respiratory muscle, then diaphragm. Patient may on ventilator, blah blah. This is what the
Yes.
history is. GBS, right? Treatment is
Yes.
steroid and immunoglobulin. Steroid and immunoglobulin for GBS. Motor neuron
Yes.
disease is a specific disease, just involve the motor neuron. There is a sensory neuron, there is a motor neuron. So motor neuron disease is atrophic lateral sclerosis, amyotrophic, blah blah. This type of terminology you heard, right? So you go and
Yes.
little read it. I did a lot of research before presenting to you. So motor neuron disease is basically just there is a motor involvement, not the sensory involvement. Here sensory involvement is also there. Dissociated sensory loss in the last line, right?
Mm.
So answer
Yeah.
is a syringomyelia. There are two words, syringomyelia. So there are two words.
Mm.
Syringomyelia is the answer. Syringomyelia. So if you break syringo means cyst, myelia means bone marrow or spinal cord. So this is a brain, this is spinal cord, right? So there is
Mm.
this is a central spinal cord, right? So there is a cyst here, anywhere in cervical, thoracic, lumbar, anywhere, right? So anywhere in the
Mm.
spinal cord there is a cyst, and this cyst depends on the size of the cyst, depends on the site of the cyst. Patient may present with the symptoms, right? So there is a cyst in the central nervous system which compresses the spinal cord and which occurs all the symptoms. Syringomyelia is a generic term referring to a disorder in which cyst. Syringo means cyst. I already simplified it. So syringo is a cyst or cavity formed within the spinal cord, right? The cyst called
Mm.
syrinx. So syrinx and cyst. Syringo or is syrinx is a cyst. So cyst can happen elongate over time, destroying the spinal cord. The damage may result in loss of feeling, means sensation, paralysis, weakness, stiffness of the back, shoulder, extremities. Syringomyelia may also cause loss of the ability to feel extremities of hot and cold. This is extremely important feature and they must give you in the scenario. So look into it.
Okay.
It may also
Okay.
lead to a cap-like bilateral loss of the temperature sensation, right, in any part. That's it. So what is the first step after diagnosis is finding a neurosurgeon who is experienced in treating this, because it's a mechanical obstruction. No? There is a cyst in the spinal cord. What you need to do? You need to remove that cyst. It is not dissolved by some medicine. It's a surgical problem. So you need to do surgery is the treatment for syringomyelia. Evaluation of the condition is necessary because syringomyelia can remain stationary for a long period of time and in some cases progress very rapidly. So whenever there is a neurological symptoms, you do it. I try to make little quick summary. Multiple sclerosis is idiopathic disorder exclusively of CNS, brain and cord, white matter. So it is nothing beyond white matter. It is nothing beyond the white matter. So everything white matter, wherever there is a white matter in CNS, central nervous system consists of two things, brain and spinal cord. That is called central nervous system because they are situated centrally. Up brain, down the line, up to coccyx is a spinal cord. Is that clear? So multiple sclerosis is a disease of white matter. That's it. Intranuclear ophthalmoplegia, INO, is an inability to adduct the one eye with the nystagmus in other eye. This is pathognomonic of MS. This is 100%. If it is present, it is MS. This is an extremely important point. They must give you in the scenario that patient may have ophthalmoplegia. It's multiple sclerosis. Diagnosis is MRI because MRI can very well clear cut tell you about the pathology of gray matter, or sorry, white matter. So you can see very well white matter, and this is the most accurate test. And if it is multiple sclerosis, give steroid. That's it. This is what you need to know. GBS, GBS is an autoimmune damage of multiple peripheral nerves. It has nothing to do with the brain. Let me tell you, right? So multiple sclerosis, brain is there, syringomyelia, brain and spinal cord is there, but GBS is a neuropathy, basically. Remember in a simple word, absolutely neuropathy, which is autoimmune in origin. There is no CNS involvement. There is no central, no brain, no spine, just peripheral neuropathy. That is how it comes, right? It's a peripheral neuropathy, right? And diagnosis is by the nerve conduction study you can do, and you can diagnose by excluding and including other conditions. And that's it. And motor neuron disease, as someone told, motor neuron disease are the group of the rare neurodegenerative disorder that selectively affect motor neurons, the cells which control the voluntary muscle of the body. Means it affects the motor neuron, not the sensory neuron. Sensation is not get affected. and they include amyotrophic lateral sclerosis, they include progressive bulbar palsy, they include pseudobulbar palsy, they include progressive muscular atrophy, they include primary lateral sclerosis, and they include primary muscular atrophy. Different name, no need to mug up, no need to get confused, just you need to know the concept. Motor neuron disease affects just the motor neurons. Sensation is not affected. In our scenario, the sensations are also affected. It's just the disease of motor neuron, and treatment is not a curative for motor neuron. Physiotherapy, pray to God, that's the treatment. That's all for today. Thank you very much. I'm wishing for a few genuine feedbacks, especially the first time who joined the class. I'm very glad spend just 5 more minutes with me so I can better understand how was my lecture and how I can improve more, or what you learned new things first time in your lifetime which you did not heard of in medical school. Open for all. I would be happy to have your feedback.
Thank you.
Anything
At
new?
at that time, I make my best score. Every score. Thank you.
Great. Anyone? Any new learning? Dr. Yash? No comment. At least give couple of comment. I would be glad.
Sir,
I'm
as
happy.
usual, you are the best person I have ever met. Because in 2019, I have you conducted some classes with us, and they were awesome. And now, after this long time, I have seen you, and you are the best one. Like the lectures you have given us before and now, they are superb. The way you explain everything, that is awesome. I can say that heads off to you, sir. Honestly, the way you explain everything today, that's very clear cut, and so much like helpful for me also, as for my career, for my like practice, and also I am preparing for my exam also.
Wonderful.
So that's helpful. Thank you so much, sir. Thank you so much.
Wonderful. Just one more question to you, doctor. What
Yes, sir.
you think that what would be the new for you today? I mean, absolutely new, which you never, I mean, heard of earlier, or something new. Must be something new, right?
For me, the new is the way you explain, like the way
Triangle.
you explain diagnosis, and then what is the diagnosis? You first have to get your diagnosis, and then what will be the next step for the investigation, and then the treatment.
Wonderful.
That's the best thing I think you gave us the lecture on today. The best learning for today for me is that
Wonderful.
one.
Wonderful. So that makes little more clarity, I guess, right? That how
Yes,
to
sir.
approach and how to think of the, I mean, not just directly jump on the answer, right? Without knowing the basic things.
Yes, for sure.
Wonderful. Thanks for your kind feedback. Yes, anyone else? Last? Anyone else? Especially the new. Dr. Uttara, any feedback?
Yes, sir. I did enjoy the session, obviously.
Very nice.
I'm new and it's my first time. Yeah, I'm just beginning to
Wonderful.
start and
So you will have a good
start
time
my
with
work.
me.
Thank you, sir.
Okay, great. Thank you very much. So I appreciate all your time, presence, and kind patience to bear with me and listen to me. I'll catch you with the next lecture. Thank you very much. Enjoy your Sunday. And also you can post your feedback in our group as well. Thank you very much and have a nice day. Enjoy your Sunday. Thank you.
Have a nice
Okay,
day.
thank you, sir.
Thank
You
you.
too. Have a good
Thank you.
day.
Bye-bye. Take care.
Bye.